Excellent. Thanks very much, George. I'd like to do a couple of things during this talk. I may or may not be successful. I'd like to put you in the mind of a surgeon, which that would be a very interesting slide to put up. I wish I'd prepared better. And discuss really how we come to make decisions about the tools that we use to treat patients. And I'll give you a few examples of those. And then I'm going to get around to talking about endoscopic therapies and how, as people who treat obesity, we might use these tools to fit in, both with currently available technologies and future potentials. So again, a perspective thing. We all know this. Obesity is terribly undertreated. We've got nihilism at every level. Our governments prevent our people making changes to our environments. Our primary care physicians don't look after obese patients terribly well. They don't identify obese patients. It's very, very rare to find hospital medicine clinics or specialists able to treat people who are obese. And in surrounding that, non-medical therapy is rampant. So we know there's a demand for medical therapy, but the demand is basically in a data-free zone. Thousands of diet books. Consumers are clearly seeking therapy, but are currently being underserviced by the medical community. To be fair, some of the reasons for this can be relatively easily explained. If you look at somebody who offers a silo therapy, so a person offering a Jenny Craig diet to their clients will see, over a matter of a year, very significant, clinically powerful weight loss in the cohort of patients that they treat. But the problem is the prescription is unpalatable to the majority of patients. And this does feed into what we've heard in previous talks, that your ability to respond to therapy early on predicts your depth and length of response. So what that means is the more tools you have in your toolbox and the more you can move from one tool to another, the more likely you are to be able to engage patients in a therapeutic journey and not have them leave. So there's a whole lot of reasons for the medical disconnect. Currently, obesity is not taught in medical schools, not that I know of. Dietitians, exercise physiologists, psychologists, nurses are not taught about obesity management beyond diets, eating and exercise. Very simple concepts, nothing complex. Obesity therapy or evidence-based obesity therapies are not prescribed in the community, in hospitals, and at any detectable level in specialist medicine. There are very good specialist medical clinics available, but they're so small and so isolated from resources that getting a morbidly obese patient into one of these clinics is a Herculean task. Into this you throw surgery. Surgery for obesity and metabolic conditions is actually just a happy accident. It's occurred because it works. And what's happened is, over time, we have learned to improve the safety of our techniques, and we've all learned to include more and more members into our teams. And it's our ability to include interdisciplinary team members, I think, that's led to our strength and led to our increasing ability to offer surgery to a larger number of individuals. But it's a difficult job offering obesity therapies in a relatively nihilistic and hostile environment. Most people who treat obesity feel that at all times they're surrounded by people who don't agree with what you're doing, but always you've got to be facing your enemy. So you're surrounded by enemies and you've got to find some way of dealing with them, of facing them all. The more team members you have, the easier it is for your team members to face other people as well. We know that surgery works. We know that 20-year data shows that it works, and it works for a long period of time. 30-year data for this particular study will be coming out within the next year or so. There's a lot of frustration amongst surgeons, and you heard that frustration echoed in our last talk. And the surgeon says, well, since surgery is clearly more successful than any other therapy, and there are many patients with unmet need, why is there resistance at every level to offering surgery to patients? Have we seen this in the past? We have. I've showed this slide earlier on this morning. There have been a whole lot of very good evidence-based trials showing superiority of surgical therapy for ulcer disease, fundoplication versus PPI therapy for reflux, open versus laparoscopic fundoplication. And these trials have ironically arrived just at the demise of these particular procedures. For a lot of our bariatric procedures, it took well over a decade and a massive data set of tens of thousands of cases to show that open obesity surgery is not quite as good as keyhole obesity surgery. And recently we've seen a phenomenon where established procedures, the laparoscopic gastric bypass and laparoscopic gastric band, have fallen over very quickly to a sleeve gastrectomy procedure that has very minimal evidence base driving its popularity. We've seen this in other areas of medicine, randomised controlled trials and analyses of randomised controlled trials comparing angiography versus coronary heart surgery, coronary bypass surgery, shows that coronary bypass surgery is safer and more effective, yet coronary bypass surgery has dropped off while angiography has exploded. Now, why has that happened? It's happened because of the ability to upscale. So in coronary revascularization, the arrival of a simple, safe, teachable, upscalable intervention has allowed thousands and thousands of more patients to have access to effective therapy. So my perception, and this is based on my desire to predict whether things work or not, is based on the feeling that a therapy to work has to be good enough, not the best, it has to be good enough, and it has to be generalisable, allowing the treatment to be offered to more patients by more clinicians. And if possible, the therapy does have to offer some advantages to the people treating the patients, because we're all human, we all have our biases. So what tools are available if you are treating an obese patient at the moment? If you start at the bottom, you've got diet and exercise. As you head up, you increase the risk. Most bariatric endoscopy physicians looking at this slide will say that the laparoscopic gastric band is riskier than endoscopic bariatrics, but it's not. But as you move north, you increase the risk profile of your procedure, but you increase the number of mechanisms that you are treating the patient with and increasing the weight loss. It's a permanent condition. Generally speaking, if you've got a permanent condition, you should be looking at either permanent therapies or repeatable therapies. So I'm finally going to get on to the talk. So what's available? The intragastric balloon was the first ever intraluminal endoscopic weight loss procedure. It's been around for almost 2 decades. The majority of patients will manage to lose 10% weight loss. About 15 to 20% of patients will maintain some effect beyond 2 years. There's 4 or 5 different balloons available, and they're all costly. So it's a short-term, costly therapy. It only works at a community level in places where it's relatively cheap or cost-effective. It's not taken off in Australia because the cost of the procedure is very similar to the cost of surgery. And so my feeling is that the balloon, although useful for some patients, because of the magnitude of the weight loss and the cost, it's probably not going to float long term. There's another relatively new and very controversial endoscopic therapy which tends to make it into the newspapers, called the Aspire Assist. It's almost like the old Roman habit of eating and then vomiting. So with this device, which is a reverse peg or gastrostomy tube, the patients are able at the end of each meal to lavage out their stomach so they don't take in the calories that they've eaten. It sounds fairly drastic, and it's unlikely to be generalisable, but it's going to be a useful tool in some patients, I suspect. What else is available? New toys such as magnets to perform surgical tasks. With this particular magnet, you can pop a gastroscope in one end and a colonoscope up the other into the small bowel, and you can bypass certain length of the small bowel in order to get nutrients into the terminal small bowel and cause neurohormonal change. Whether this will translate into effective therapy is actually unknown, but these are technologies that are being floated to us, and you can see an X-ray view showing the magnets being coupled. And in this particular patient, they also performed a laparoscopy, which you'll see just showing the small bowel joint to small bowel. It's actually a very complex way of doing what a laparoscopic surgeon could do in about 10 minutes, unfortunately, but that irony is lost on our gastroenterology colleagues. And this is the magnets joining together, about to form the anastomosis. What else is available? There's a whole raft of procedures: duodenal sleeve liners, gastroduodenal sleeve liners, transmalaric shuttles, Terrace device, duodenal resurfacing, endoscopic stapling device, endoscopic suturing devices. There's ones like the endobarrier, which is partially effective but riskier than surgery, which is still under evaluation, but I suspect probably won't take off. The procedure that I'm going to talk about mostly is down on the bottom right, the Apollo overstitch device, which is being used in many hospitals in many countries around the world to create a deformed stomach, not like a sleeve, but perhaps similar in some respects, with weight loss. How do we do the procedure? You pop an endoscope into people, and what you're trying to do is pull the stomach in, which makes the stomach less wide and shorter, and use a suturing device, which is here, to go through the stomach, pick up a full thickness bite, and imbricate the stomach down. This is endoscopic surgery because with this device you are equally able to pick up pericardium, colon, gallbladder, pancreas, and IVC. So there are some potential concerns with using these sorts of technologies in a risk-free way, but so far the procedure does seem reproducible. So what you're seeing here is the end of a suture line being performed, and then a knot is tied, and you can see as the knot's tied, the stomach will slowly concertina down. And over time, the stomach seals and sticks reasonably permanently. There we go. And so in doing this procedure, suture upon suture, plication upon plication is put into the stomach to reduce its volume and induce appetite suppression and satiety. If I could. No, I'll move on. Actually, I'll let the video play for a minute because I think I still have time. I'm near the end of my of my talk. It does show that endoscopic surgery is a relatively messy field because you're inside the stomach, and as you do the procedure, your space becomes progressively less and less, and you can see the stomach now, distal stomach, becoming progressively more narrow. And there's the end view showing about a cup-sized fundus and a narrow tube for food to pass down into the antrum. So what are the results of this new procedure like? Reasonably consistent results out to about 2 years from multiple sites worldwide, and that reproducibility in multiple sites is one of the reassuring things. There is a 2% major complication rate, and in Australia what we have with the bariatric surgical registry data shows a 2% major complication rate from sleeve gastrectomy. So this is a procedure that should be viewed as being as morbid as surgery. Just because it's done endoscopically doesn't make it necessarily minimally invasive for the patient who's having it done. It provides patients with 14 to 19% weight loss at 2 years and a failure rate, or less than 10% weight loss in about 1 in 5 patients. It's got a potential for repeatability, but there are no data on that yet. So these are the sorts of outcomes you could probably expect to see from this procedure. Does this laser put? There we go. So about 1 in 5 patients lose a small amount of weight. The dominant number of patients will lose a clinically significant amount of weight, and the odd outlier will lose a lot of weight. And you can actually apply this sort of rationale to any of the obesity treatments that we use. So if you want to have a patient who should lose 25% of their body weight and above, this procedure is likely to achieve that for them in less than 1 in 20 occasions, so it may not be appropriate. So why am I interested in this? I'm excited by the prospect of increased physician input into the management of obesity, which Francesco has pointed out as being a long-standing problem. Combined with newer medical therapies or pharmacotherapy, we are slowly inching towards the concept of patient-centred care by pulling more people into the team. So in the last couple of decades, we've been continuously involving and improving our collaborations between our teams and our patients to better meet their needs and anticipate problems. The ability now to potentially bring in a large cohort of physicians into obesity management has the potential to magnify our effectiveness and increase the number of patients we can treat. And that will push back against the culture of nihilism which otherwise predominates. Are there risks? Yeah, these procedures may not be reliable beyond 2 years. We'll find out. Potentially they might make further treatments more dangerous, so if they are applied to the wrong patient, it might increase their risk long terms. We do have a risk of data not being captured. That's data for safety and efficacy, and we need these people to join our people performing these procedures to join our registries. We also create the risk of creating yet another separate silo of obesity interventionalists who work separately from us, creating competition rather than collaboration. And the rollout of these sorts of procedures may be and will likely be complex and risky for patients and the profession if we don't do it well. What I think is the more procedures we have, the better we will be able to offer patients therapies depending on what their requirements are. So we know how patients respond on the bell curve to the best dietary therapies, to diet and exercise, now endoscopic therapies and the bypass. So we should, in the future, as teams, be able to apply these therapies to our patients based on their requirements, not our requirements. So my conclusion is, after a decade or more of failed starts, I think endoscopic bariatric surgery looks to have arrived. Where we take it doesn't actually depend on the technology, but on our intent as practitioners. Thank you.